Good afternoon, everyone. It's my great pleasure to be talking to you today about allergy testing in allergic rhinitis. And it's actually interesting that although I work in London, I'm talking to you from Cyprus. Now, the most important thing that you as an allergist or ENT surgeon can do is to take a good history from your patient. And no amount of testing will compensate for an inadequate history. However, having taken that history, you may have some idea about what the allergy might be, and you can confirm that by using various tests. And I'm going to talk to you today about skin prick tests, other tests for IgE and for components, challenge tests, and finally other things that you might like to do, such as nasal smears, nitric oxide measurements, and biopsies of the nasal mucosa. I think you probably all know what skin tests are. A small drop of allergen is placed on the skin. It is then pricked gently into the skin, and within around 15 minutes, if it's positive, a wheal will develop and a flare. Negative is employed, that's saline, and a positive control is histamine. And you can see what the arm looks like at the bottom of the slide here. And this patient is positive to items 2, 4, 5, and 7. Well, what use are these? They are wonderfully useful because they are so immediate. And you can convince the patient very easily, look, you tell me that your symptoms come on when you meet X. Here is X on your skin causing a reaction. A similar reaction takes place in your nose, but unlike your skin, your nose can also run and you can sneeze and it can block up and itch. So they are useful. They're also cheap. They're very good, actually, at eliminating allergens. They've got a good negative predictive value, which is better than their positive predictive value at a 3 millimeter cutoff, which is the usual cutoff used. You should use a validated extract, but it is possible sometimes to use fresh material, especially if you're looking for the pollen food syndrome. And many of those allergens are heat labile, so you cannot buy them as sterile extracts. A medication, if you're doing drug allergy, or if you're looking for latex allergy, then you may want to prick through a latex glove. And here's a patient who's had their skin prick test. You can see a very nice positive control, a negative control, and a couple of positives. The basis of the reaction is quite simple. The patient has already made allergen-specific IgE, which is sitting on mast cells that are therefore armed. When the allergen cross-links those IgE molecules, as you can see in the diagram, the mast cell degranulates, releasing mediators, including histamine. And histamine then causes that reaction on the skin because of its effects on vasodilatation and vascular permeability. It is part of the early phase allergic response. And here you can see an unfortunate individual who is sensitive to all the beers tested because there's a common component in them. Now, in order to do your skin prick test, you need to know what the allergens are in your locality. In the UK, by doing 4 house dust mite, grass pollen, cat and dog, we can pick up over 90% of our rhinitis patients, always including, of course, the negative saline and the positive histamine. Now look at the arm illustrated here. There are several things wrong with this. One is that the test is rather too low down on the arm. Another is that nothing has come up positive, not even the histamine. This is a failed test, false negative. You will need to do either a test on serum or an allergen challenge. And this patient has probably been taking antihistamines or has used a lot of corticosteroid on that particular area of skin. So false negatives occur, and as do false positives. Besides those basic few tests, having taken a good history, you may well find there are other things to which your patient will need to be tested. For example, latex in a healthcare worker, wheat and amylase in a brewer or baker, animal contact, the relevant animal, possibly a horse that the patient meets every weekend, is the relevant source of allergen. Molds may well be relevant in damp climates, damp housing, or in the autumn in the UK. Foods very, very rarely cause allergic rhinitis, although patients often think it's food-related. It can be in small children with things like milk and egg, but then this is not an isolated rhinitis. They will nearly always have other symptoms like asthma, eczema, and failure to thrive. There can be complications in that sensitization to pollen allergens can cause reactions to various foods, and I'll explain a little bit more about that in a minute. The patient in this arm has multiple positives. They may not all be relevant to that patient's disease, so check those positives in the light of the patient's history. I've mentioned some of the pitfalls, the antihistamine, the topical corticosteroids. Your test is only as good as the quality of your extract, and some allergens may not be available for skin prick testing. Sesame is a particularly difficult one. Species differences may be relevant as well. What about safety? Well, systemic reactions to skin prick tests are fortunately extremely rare, particularly with inhalant allergens, as you can see from these papers here. 0.08% in the first one, 0.4% in the second one, but most of those were to what was called aeroallergens and food. And in the final one, 0.03%. So you are unlikely to have a systemic reaction during allergens which are inhaled, but you should always have the ready kit to treat anaphylaxis there whenever you are doing skin prick testing. And the adrenaline should be in date. What happens if you can't do skin prick tests, or if your skin prick tests are unhelpful? You might want to do blood tests looking for serum IgE. And this can give additional information, especially if you look at components. The most common method in the UK is called immunocap. It's a radioallergosorbent test, and the positive cutoff is 0.35 with a range of 0 to 100. The positive and negative predictive values are very similar to those for skin prick tests, and the relationship between a RAST and a skin prick test for the same allergen is usually pretty good, but there are exceptions, and these tests are less good for labile heat-sensitive allergens. And here's what the test looks like. The allergen is in the solid phase, and the sample serum is added to the ELISA well. A secondary, it then binds if the allergen is present to which the antibody has been made. Washing is carried out, and then a fluorescent labeled second antibody is added, allowed to bind. Washing is carried out, the developing agent is added, and the fluorescence is then measured and converted to the concentration of antibody present. As I keep mentioning, a positive test does not represent allergy, it represents sensitization. And you must always interpret them in the context of the history. The gold standard is a challenge test, which we'll come on to shortly. Now, Isabel Skypala looked at what is now called the Porron food syndrome. And she found that in patients with allergies to pollen, a large number of them had positive skin prick tests to various fruits and vegetables, which were completely irrelevant. They were not related at all to symptoms. And the figure was highest for dill, but pretty high for potato, nectarine, grapes. So do remember that a positive skin prick test is not necessarily something that you have to then avoid. You can work this out by looking at component-resolved diagnosis. So far, we've been looking at whole extracts of allergens, and they contain multiple different proteins. Patients may be sensitized to only one or two of the molecules in that extract, and different patients will see different molecules, immunologically speaking. And the different components that are seen hold different reactive possibilities. So extra information can be made by doing component-resolved diagnosis. And here we see the ISAC, the immunosolid phase allergy chip. And on only 30 microliters of blood, you can look at multiple allergens and see which one the patient reacts to. Now, this is becoming very important in food allergy, particularly things like peanut allergy, where the molecule seen will determine the severity of the reaction and the likelihood of anaphylaxis. It's also relevant to asthma in allergic rhinitis, with patients seeing more components, for example, to artemisia in a Chinese study and to house dust mite, being more likely to develop or to already have coexistent asthma. And there's a nice paper here that you might like to take a look at, looking at component-resolved diagnosis in allergic rhinitis. It's not yet absolutely necessary, but in certain individual patients, it might be helpful. Now, what happens if your tests are negative? What are the other possibilities for rhinitis? Well, they are multiple. There are many causes of rhinitis which is not allergic, and you may need to do other tests in order to establish a diagnosis of one of these. But before you go on to that, let's not forget the fact that local allergic rhinitis exists. And in this, the IgE sensitization is confined to the nasal mucosa. So skin prick tests are negative, serum tests are negative, and the only way to diagnose this is by doing an allergen challenge into the nose. So let's look now at nasal allergen challenge. A standardized dose of allergen is usually applied. Both the early and the late phase symptoms are measured. You can collect nasal secretions and measure components in that. Now, this is primarily a research tool, but occasionally it's useful in clinical practice to make a definitive diagnosis, and this can be very important in occupational rhinitis, because occupational rhinitis often precedes occupational asthma. And if you can identify the relevant allergen, get the patient away, you may stop them getting irreversible asthma. It's also useful prior to allergen immunotherapy, particularly with an allergen such as house dust mite, where the history is never entirely clear that that is the major driving allergen for the patient. It can differentiate between allergy and sensitization to determine whether that skin prick test is really relevant to the clinical symptoms. And it may provide a measure of severity with the more severe patients responding to a lower dose. And it can identify those local allergic rhinitis patients. In order to do it, you need to symptom score your patient in a quiet room where they've been allowed to equilibrate prior to the reaction for at least 15 minutes. And that can either be a numerical scale or a visual analog scale. Once you've explained to the patient, they have to make a mark across the line for how bad their symptoms are. And it should always include some objective measurement of the airway, because symptoms alone are not enough. The simple one shown here is peak nasal inspiratory flow, and I know you're having a lecture on airway measurements, so I won't push these points, but I would never use the NIP meter like this. I would always have somebody else holding that meter very firmly onto the patient's face with another hand behind her head to make sure that the seal is absolute. It's a very useful measure. It's not standardized, and it is affected by chest conditions such as asthma and by neuromuscular conditions, and to an extent, it's also voluntary. The patient can sniff as hard or not as hard as they like. It's also reduced by alar collapse. You need to be careful about that. But used well, following a nasal allergen challenge, you can see a very nice significant drop in nasal inspiratory peak flow within the first few minutes and lasting for an hour or two. And occasionally you will also see a late phase response with a second drop. And besides that, you can use acoustic rhinometry, in which alar collapse does not matter. So if you think you've got alar collapse, probably do both measurements each time, or you can use rhinomanometry, but that is technically very demanding. Well, if you've done your allergen challenge and it's negative, you might want to do one other test, which is looking at what cells are present in the nose. You can collect cells very easily using this little plastic stick with a tiny cup at the end. It's called a rhinoprobe. It comes from Texas. You take a sample from the nasal mucosa, you scrape 3 times from front to back along the bottom of the inferior turbinate, rub it onto a slide, dry it, fix it, and stain it. Hematoxylin and eosin will do very nicely because what you're primarily looking for are those eosinophils. They will be present not only in allergic rhinitis, also in some forms of nasal polyposis and in non-allergic rhinitis. The percent needed for a diagnosis of non-allergic rhinitis with eosinophilia varies from 5 to 20%. But what finding eosinophils does give you is some idea of the possible pathology and also the knowledge that this patient is likely to respond well to corticosteroids. You can as well collect nasal fluid before and after challenge by putting a little soft sponge inside the nose, leaving it there for a couple of minutes, and then extracting it into a sterile tube where you can add diluent and measure various cytokines. The rapid reaction occurs with tryptase, so you need to get your sample very quickly if you want to look at that. The cytokines and eosinophilic cationic protein come up later, several hours afterwards. So then you need to be taking this sample at around 6 hours. Or you can do various samples at different times, as shown there. If you're still worried about what is going on with your patient, these blood tests may help to work out the situation. And these are the sorts of diseases in which the blood tests are useful. A serum eosinophilia is usually found in concurrent asthma, in nasal polyposis with aspirin sensitivity, and also very high levels in vasculitis, what used to be called the Sjögren-Strauss syndrome and is now eosinophilic paucigranulomatous arteritis, and also can be found in allergic fungal sinusitis. So very high levels of eosinophils may help to give you the diagnosis. You may also find a low level of neutrophils, giving you an idea that this patient may have an immune problem. Total IgE is not often a very helpful measurement. It is particularly high in fungal hypersensitivity and in some patients with nasal polyposis, and it can be raised in atopy or not raised in atopy. So as an isolated measure, it is not very useful, but when you're looking at it together with serum IgE tests, it can give you some idea of the relevance of them. For example, if your patient has atopic eczema, their serum IgE will be very high and they'll have a lot of positive reactions, many of which are irrelevant. CRP or ESR can give you an idea about systemic disorders such as vagus, Sjögren's, and autoantibodies can also help with that. Immunoglobulins may help to teach you about your possible immune deficiency in your patient. And again, systemic disease can be manifest in different dysfunctions of organs like the liver and kidneys, so those measurements are worth making. Hormones can be helpful. Low levels of T4 can give you a rhinitis type picture mainly with obstruction. Pregnancy can also cause rhinitis. And finally, urine examination is useful. A dipstick test can show you red cells in a vasculitis, but also you can measure drugs of abuse such as cocaine, which can give you a picture in the nose very similar to vagueness. Now, one of my favorite tests to do in allergic and non-allergic patients is nitric oxide. This little gas has antibacterial properties and is also a vasodilator. That's how Viagra works. It stimulates ciliary beat frequency, and it is made by nitric oxide synthase from L-arginine. And there are constitutive and inducible forms of this enzyme. And in the upper airway, the inducible form will be switched on in response to pathogen and inflammation. So the levels may correlate with inflammation in the respiratory tract. Also, that inducible enzyme is deficient in primary ciliary dyskinesia. So very low levels in the nose may say, this is not allergy in this child, this is PCD, or almost certainly. Here is someone having a test, levels reasonably high in the nose, but low in the lower airway. Because where nitric oxide is made is predominantly in the sinuses, where it is continuously produced at levels of 20 to 25 parts per million. And this is part of the immune defense of your airway. In the nose, the levels are very variable. We find between 400 and 950 with our machine. And in the lungs, they are usually low, less than 20 parts per billion. So in the nose, measuring nitric oxide is a little bit like taking the temperature. Very high levels mean inflammation. Very low levels mean probably that the sinuses are blocked off by polyps or swelling or cystic fibrosis secretions, and ultra low levels alert you to the likelihood of primary ciliary dyskinesia. So there's a wide normal range, but in children as well, and adults, you can measure the exhaled NO from the chest, and high levels of that, over 50 in adults and over 35 in children, are consistent with lower airways eosinophilic inflammation and the need to treat that probably with inhaled corticosteroids. A recent paper has suggested that actually you can use nasal nitric oxide in the differential diagnosis of allergic and non-allergic rhinitis. They found that in allergic rhinitis without sinus inflammation, i.e. the sinuses were patent, the highest levels were seen at well over 1,000 compared to the other conditions. Non-allergic rhinitis with sinus inflammation showed the lowest levels of all. Their low levels were around 500, a mean. And they found that they could use this to discriminate between allergic and non-allergic rhinitis with acceptable sensitivity and specificity. And the reference to that paper is there, if you'd like to look it up. It's 2020. Finally, if you're not sure what is going on with your patient, if they possibly have allergic rhinitis, but they don't seem to be responding to treatment, or if you're a little bit worried that they might have vagueness because they have a nose that looks like this, a bloody nose, possibly with a septal perforation, a lot of crusting, the thing to do then would be a nasal biopsy. And it might show vasculitis, but it might also show what this biopsy shows here, You can see the little dots inside the cells. They are Leishmania donovani. This patient has leishmaniasis. And I've seen a very similar patient, an English expat who lived in southern Spain. These are patients from Sardinia in Italy. So don't hesitate to ask your ENT colleague to do a biopsy if you're really not sure about what's going on. Thank you very much for listening to me. I'd like to thank this young man here, who is my son, Guy Scadding, who has lent me several of these slides. A few years ago, we did a paper for IACI on diagnostic tools in rhinology, which is on clinical and translational allergy. There's going to be a new update of this soon in an online journal called Frontiers in Allergy in the rhinology section. I look forward very much to your questions.